All right, so this is our part 2 of our non-cancer or non-pet cancer imaging talk. The last one, part 1, was a MIBG focused talk. This one is going to switch gears into this particular study. So looking at this thing here, man, those kidneys look dark. Very hot kidneys. No bones, not normally anyway. Spleen is looking toasty, very hot spleen, and very hot kidney. So this is an octreotide scan. Remember, we see the liver, we see the spleen, we see the liver, see the spleen. So this is sort of the last one. Kidneys, yes, no kidneys. So the red pulp of the spleen expresses a high affinity for the somatostatin receptor, which we'll talk about here is how octreotide works. The liver actually doesn't have somatostatin receptors. The uptake there is like a non-receptor mediated thing. Don't worry about that. The thing to know is that the spleen, the liver uptake is less than the spleen, which is the opposite of a MIBG scan. Also, there's the kidney thing, right? Remember, MIBG doesn't have kidneys, and the way to remember that is you wouldn't want it to have kidneys because you're trying to look at the adrenals. With octreotide, you do have the kidneys, and where MIBG has a hot liver, octreotide has a hot spleen, so that's the opposite. The liver-spleen relationship is switched. This is something else that I mentioned in I think it was the GI talk, was sort of, if you're given a SPECT image that's through one plane and it's a liver lesion, sort of how to work through what the test is. So first question is, what is the scan? That's always the first question. So anytime you're given a Nukes mystery thing that's like a two-parter, like they're not asking what the scan is, they're asking you, what the imaging findings is or that. Go through the process, make sure you know what scan it is, otherwise you're going to end up getting tricked. So just reviewing that algorithm real fast here. So what scan is it? So 3 basic options when you look at the liver. So the mechanism is, can you see the aorta/IVC? If you can, it's an RBC scan. If you can't, you're thinking sophrocolloid. The blood half-time in blood is very short. And then if the kidneys are super hot, then you're doing with octreotide. So what if they don't show you the kidneys? They'll show you the kidneys if it's an octreotide scan. I promise you that we'll have the tops of the kidneys in there. Otherwise, it's an incredibly shitty thing to do. You could also think about the fact that the spleen is going to be hotter than the liver. So path, of course, is going to depend on what scan it is. RBC scans are going to be used to show you mangiomas. Sophrocolloid is going to be used to show you FNHs, even though only 30% of them are hot. But for the purpose of multiple choice, they're always hot. And octreotide is going to be various neuroendocrine tumors, which we'll talk about in this talk. So in this case here, you can see that this is an RBC scan. All right, and that makes that some angioma. So all right, so running through the same algorithm real fast here. So this versus that, we've got an orange and a red. So orange, what's our first question here is always, what scan is it? Not showing me kidneys. You are showing me kidneys, so I know this is your octreotide. That means that's your sophrocolloid. Also, look how hot that spleen is relative to the liver. This one, it's sort of similar. You'd expect the liver to be probably a little bit hotter there. So in a normal situation where he hasn't had colloid shift. All right. And then, of course, what is it going to be? FNH, and then some kind of neuroendocrine thing. We'll talk about that. So just rehashing this real fast, sort of related. So sophrocolloid means there's some functional hepatocytes there. None of those things are going to have that. HCCs can be seen. They're a tumor, right? So gallium scan, abscess. Gallium works because it's a non-specific inflammatory thing. And then remember xenon for the focal fat because it's a water or fat soluble. All right, so moving on with the new stuff. That was the review. Here's the new stuff. So I want to introduce a character to you here. This is King Apud. Sounds sort of like a royal name to me. He's the big daddy or the king. And what does that stand for? Amine precursor uptake in decarboxylase system cells. So this is a cell line that has all the neuroendocrine tumors. And that's going to include carcinoid, pituitary adenomas, islet cell tumors, medullary thyroid, PHEOs, neuroblastoma, and small cells. All right, and all that stuff sort of goes together. All right, so let's talk about how some stuff works. So somatostatin is you may remember from med school, it's a hormone that exists in the body and acts on all those receptors for those tumors that I just mentioned. So we can't use somatostatin for imaging. Why not? Well, because it has a biological half-life of about 2 or 3 minutes, which basically makes imaging it worthless because it's so short. Its biological half-life is so short. So to deal with that, they developed this analog octreotide. And it has a half-life of about 2 hours, so it hangs around a lot longer, and therefore you can actually use it for imaging. So there are 5 receptors, or 5 different expressed somatostatin receptors, but only 2 of those 5 will bind the analog octreotide. So somatostatin will bind on all 5 of them, but the octreotide will only bind on 2. However, it's not really a problem because 80% of these enteropancreatic neuroendocrine tumors express those, specifically the subtype 2 ones. So the vast majority of them will actually be sensitive. Obviously, sensitivity is going to depend on the receptor subtype and how much it's expressed. So we have our agent. Now we have to tag it with something that we can actually image, right? Now in the prior lecture for MIBG, we used iodine 123 or 131. For octreotide, typically used indium 111. Okay, so what do you need to know about indium 111? Here are the things that I would know about it. First of all, it's a medium energy, and it has 2 peaks. So something like that. So what are these peaks? Around 170, around 250. Those are the peaks. I said it was medium energy, and that means you use medium collimation. The half-life is around 3 days, but don't just remember that it's 3 days. You gotta, because there's other stuff that is 3 days, so it's actually 67 hours. It could ask you that a whole bunch of different ways. It could straight up ask you that. It could do math problems with like decay, how much is left over so many half-lives and days and stuff like that. And you have to know the 67 hours to be able to do any of that. So I mentioned there's multiple tracers that have a half-life of around 3 days. Gallium, indium, and thallium. Okay, so GIT, G-I-T. All right. Now I have a way to remember that.
Tim Peeler thought he was calling coyotes.
Instead of them, him.
He got something that frightened even the self-proclaimed mountain man.
This thing was 10 foot tall. He had beautiful hair.
The Sasquatch going after his dogs.
I come out here and rough talked him and run him off.
Got him to leave, called 911, then the creature came back.
And I said, get away from here. Get. And he went right back out that path again.
Deputies filed a suspicious person report, and Tim is still recalling the details.
He looked like he had 6 fingers on each hand.
So that's my method for remembering that. GIT. All right, gallium, indium, thallium. GIT. And so this is the way that I keep them straight between, because remember I said, so the first thing I do is I say, okay, what are the ones that are around 3 days? All right, GIT, okay, I remember that. Then I go through the following mental exercise. You could write this down. Gallium-67 is not 67. 6, 7, 8 instead. So 6, 7, 8, 78. So gallium has a half-life of 78 hours. Indium is 67, so I for I. And then thallium is 73, T for 3. So that's the way that I keep that straight. Another way you could remember it is that gallium has the highest energy, so it has the longest half-life. It doesn't really go together, but you could just ways to remember it. So this is how I keep them straight. All right, so here's a case. A real classic look here. So we've got this desmoplastic reaction. Remember, that's not actually the primary. That is a MET, and so this is a carcinoid tumor. So most of the time, the primary is actually very small. It's difficult to image. So that's where you have some utility for octreotide. So how sensitive, how good is octreotide for carcinoid? It's pretty good. It's like 90%, which is way better than CT or MRI. So pharmacy called, and they are all out of octreotide. Is there anything else you could use? So you can actually use MIBG for that as well. So how do they stack up against each other? So which one's better? So you got a carcinoid tumor. You got the option to give MIBG or octreotide. Which one are you going to pick? So this is a talk on octreotide, so you're going to pick octreotide. But it does actually have higher sensitivity. So neuroblastoma, MIBG, carcinoid tumor, octreotide. So I mentioned also islet cell tumors, and there's a whole bunch of different ones. This is from the pancreas talk. Remember, we've got sort of major players, insulinomas and gastronomas, and then your minor players. So let's talk about these real fast. So just as a refresher, remember that insulinoma is the most common. They're usually benign. Only about 10% of them are malignant. Whereas gastronomas often actually occur in the duodenum, right? It's that gastronoma triangle. They're often malignant. They are the most common associated with MEN. So if they tell you the patient has MEN1, he's more likely to have a gastronoma than an insulinoma. If you're just dealing with a straight-up islet cell tumor, it's more likely to be an insulinoma. Octreotide sucks for insulinomas. It's really the only one out of these. Well, it's the one to remember for sure out of these that it sucks with. And then octreotide is particularly good for a gastronoma. So those are the big differences. So most common overall, most common in MENs, usually benign, usually malignant, shitty on octreotide, good on octreotide. Okay, so piece of trivia here. If you are trying to do an octreotide scan on a patient you suspect has an insulinoma, why might you think they have an insulinoma? They could tell you that they've got episodic hypoglycemia. So the although the agent's not expected to exert clinically significant effects, it could potentially produce a hypoglycemia, and because of that, you're supposed to have IV. Some people tell you to give them IV glucose prior to the exam. Some people will just say have it ready, from the pharmacy prior to doing the test, just in case. Now let's talk about non-functionals. Remember, these guys are big and bad. They typically present late because they don't have a syndrome associated with them, so they have a bad outcome. So what is the next step? And by that I mean, what test do you want to order for this? So this is sort of like the insulinoma also in that it's sort of non-functional, so maybe it doesn't have the proliferation of the receptors that you would normally expect. So what test are you going to use for that? You can actually use PET. Because they're, just because they don't have the receptors doesn't mean that they're not hypermetabolic. Man, these guys are big and bad. So non-functionals, next best test is FDG PET. All right, what about this guy? That thing. So we have a T2 axial coronal. It's an adrenal mass, right? And it's T2 hyperintense. So it's pretty classic for a pheo, right? CT and MRI are excellent for finding the mass, but they're totally nonspecific. And, pheos appear similar to other adrenal lesions. And there's papers that'll tell you only 65% of pheos are correctly diagnosed. 35 are misrepresented as malignant. Can pheos be malignant? Sure, but there's a 10% rule. 10% everything for pheos. 10% bilateral, 10% this, 10% that. So 10% are malignant. So if you're going to choose a test between MIBG and octreotide, which one do you pick? And I did mention in a prior talk that you can use an MIBG. So it's a little bit of a trick question, and it depends on what kind of a pheo you're dealing with. The nice kind or the mean kind. So remember, 10% of them are the mean kind, the malignant kind. So, and there's that, rule of tens, like I mentioned. So, if they are benign, the MIBG is actually better. The malignant ones, the octreotide is actually better. So, in general, a positive MIBG scan reliably confirms the presence of a pheo, and a negative scan reliably excludes the pheo. But just know that the malignant ones act less and less like an adrenal medulla thing, so the MIBG is better. Both octreotide and FDG are actually better than MIBG for the malignant ones, but octreotide's like way cheaper. Now, why don't you just go that way first? Well, the iodine 123 medium energy photon is better for SPECT, so some people will gravitate towards that as well. All right, so next case. All right, so we got a mass. This here is probably the most classic thing that you're used to seeing. This sort of splitting of the bifurcation here. Moving across there. Really hyper enhancing, right? So splitting these vessels. So this is a paraganglioma. Now, what kind of paraganglioma? You remember from the neurotalk, there's a whole bunch of different kinds. But the one that is pushing the vessels apart like that, that's your carotid body tumor. This is actually the most common spot. And they're also often multiple when you see them in that location, so you're supposed to look for the second one. And if you were going to embolize them, the ascending pharyngeal artery is the one. So for paragangliomas, the indium is actually considered, or the octreotide is actually considered better, with a sensitivity of around 94%. MIBG scans are less sensitive and specific because, and here's why, because MIBG only concentrates in functional paraganglioma. So if they're making norepinephrine, then they work just fine, but if they're not, then they don't, but they still typically have those receptors. So they can produce catecholamines, but they don't have to, and it's a better first step to go with the octreotide. Alright, so here's a thyroid scan, and I've given you a significant hint here by telling you there's an elevated calcitonin. So remember, the most common thyroid malignancy is papillary subtype. So given no hinting information, remember the papillary is popular, they would also probably show you microcalcs. But then when they start telling you stuff like this, elevated calcitonin, or they could hint at an MEN syndrome thing, then you're going to think, well, that's a medullary subtype. Medullary subtype is special, has an MEN2 relationship, and although CT and MRI are typically used in the workup, indium 111 octreotide is often used early on for metastatic disease. having said that, none of those modalities are particularly sensitive. So, what if it's negative or inconsistent with the anatomical imaging? What's the next step that you do? You get a PET. So, medullary thyroid cancer is relatively aggressive. The cells are very active metabolically, so FDG PET is very reliable, especially when you've got a rising calcitonin level. The sensitivity is like 95-96% relative to octreotide, which is like 40%. Now, why is it so low? Probably because it doesn't have those somatostatin receptors, or doesn't have the types that octreotide, remember, only 2 out of the 5 the analog actually worked on. So if they're not expressed, then you won't pick it up. So why not just go to FDG first? Well, it's fucking expensive, right? So you're supposed to go cheap first, at least for the purpose of multiple choice. So, and this is how it works in the real world. Octreotide is the initial scintigraphic procedure for looking for medullary thyroid. If it's negative or it's inconsistent, and then especially if you're having a rising calcitonin level, then you go to PET. All right.